Welcome to this special live recorded episode of the Talking Health Tech podcast. My name is Peter Birch. We're here with a live virtual audience in the chat. If you're attending today, make sure you drop a message. Let us know where you're joining from, what you're looking forward to in this session today. So I'll be joined by two very special guests to discuss the critical role of technology in enhancing pre-hospital care. So I will bring them onto the stage in just a second. So for those that are unfamiliar, the Talking Health Tech podcast, we have 2 episodes a week going out on audio podcast players and video, and you can catch this session in about 4 to 6 weeks when it's released to our broader audience. But we want to shape the conversation with people's perspectives from the chat, and we want to make it a dynamic conversation because it's an important one that I think impacts a lot of healthcare providers and systems, not just in Australia but around the world too. So do drop a message in the chat. Let us know you're here, and looking forward to learning more about what you're after for this session. So I'm going to bring onto the virtual stage our 2 guests today. We've got Stacey Clifford and we've got Soren Rasmussen. G'day. How are you?
Well, thank you.
Good. It's great to have you here. It's great to have you here at some of you in appropriate time zones and others at times that you shouldn't otherwise be awake. We can set that context in a second. But Stacey has a clinical background with 26 years in operating theatres, specialising in trauma, transplant, cardiac and complex anaesthesia, 8 years experience in digital health transformation, both client and vendor roles as well. She's currently focused on client engagement and all things regionalisation here in Australia and product market fit for the amPHI solution in Australia and New Zealand, actually. Then we've got Soren Rasmussen. He's got 22 years of medical systems experience ranging from diagnostic devices to advanced decision support within medical devices. And in the last 10 years, he's really been focused on pre-hospital systems as product manager for amPHI and facilitating its rollout globally. So no stranger to a 4 a.m. Session at all. But we've got Fazia in the chat there as too. Teresa wants me to reenact the different sounds that ambulances make around the world. You'll have to be following me on LinkedIn there to get the full context on that one. But look, I might throw to, as we kick off this conversation, and for those that are unfamiliar, we want the conversation to be really focused around this pre-hospital space in healthcare because it's a hot topic right now, and there's ambulance ramping always gets front and center no matter where you are in the world. Because it's got a huge impact on system efficiency within healthcare, but obviously patient outcomes as well. We've got increasing demands on emergency services, so we've got to find a way to improve efficiency in pre-hospital care, so before a patient is treated there. So let's dive into it because it's great that we've got both the global perspective here in the conversation as well as being able to put it within the Australian-New Zealand context. I might throw to Soren firstly to set the stage a little bit more in terms of the context of these issues that are affecting ambulance services, the ramping, the stuff outside of the ED, particularly at a global level, and why it's become such a critical issue in healthcare now. And then I'll go to Stacey for the local perspective.
Thank you very much, Peter. Well, first of all, I think it's important to state that ambulance ramping is not a result of an inefficiency in the ambulance service only. Ambulance ramping is a result of saturation of what I call the entire care chain. So, which means, of course, the ambulance is a crucial part of that when we talk about the pre-hospital area. And you can say the mantra all over the world right now is actually to avoid ambulance ramping by, you can say, putting up the idea of saying that you want to apply the right care to the right patients at the right time. And that's a nice, easy stated ideal, but of course, how to do that is very, very different depending on where you are in the world, which resources do you have available, which distances do you operate with, you know, which local services are available and so on. So that means that it's very, very quickly, highly complicated riddle to find out how we apply the right care. But you can say you want to apply resources when necessary, when needed. And as resources become sparse, as knowledge, as you could say, yeah, personal resources become sparse, they become critical. And as they become critical, you try to ensure that that your resources are applied exactly when needed. So it's a lot to do. It means that you also start to push, you can say, a lot of the assessments and so on the patients. Instead of just being a transport service, you also push a lot of knowledge into the ambulances. That simply to ensure that that you can potentially already mitigate the situation on site, potentially avoid bringing the patient to the hospital. We're actually also starting before dispatching an ambulance, ensuring that we actually only dispatch ambulances to the patients that are actually in need of an ambulance in that situation. So you can say it has a lot to do with it's, I think the negative way of saying this is to say we need to save resources. I would say we need to apply the resources where they're most relevant and where they're most needed.
Yeah, well, you think about efficiency and the need to be able to do things, do more with less within healthcare. You're so right. Often the mind goes to healthcare is delivered within the four walls of the hospital system if you're not always active in it day to day, looking for innovative ways to address it. But, gone are the days of purely the ambulance is just there to get the patient from A to B in whatever state they were at A. If we're putting more expectations on those that are doing the transportation, and even earlier, as you said too, they've got to have the right resources and tools to be able to do it. But Stacey, very familiar with this region, help
Yeah.
fill in a bit more gaps.
Yeah, it's definitely a very big focus in Australia, ambulance ramping. And in fact, the AMA released an ambulance ramping report card late last year to look at statistically what's happening state by state and what the issues are and where we're focusing. I mean, you're right that it is for those of you that aren't sure of what ramping is, it's essentially ambulances delivering patients to EDs, but they're not able to hand the care over for a variety of reasons. Usually, ED can't get the patients out of ED because there's either a lack of beds or there's a lack of resource, so they're kind of bound. And there's actually a really big move in Australia at the moment to look at this in terms of national hospital funding and to help split that cost up between the regions and the federal government. Because ambulance services are doing a whole lot more. As you said, Peter, it's not just picking patients up and taking them to hospital. There's a lot of ways that they're trying to divert that care out of hospital and back into the community through secondary triage, through virtual or in-home care, through hospital avoidance programs. So, there's a lot of ways in Australia that we're really trying to tackle this issue and try and divert patients. But there's a big economic impact here too. A lot of people are struggling economically, and it's easy to turn up to ED because you don't have to pay at a public hospital. So, we've got to kind of address how people are able to afford and access healthcare, out in the community as well. It's a big issue.
It's a huge issue, and locally in Australia, that we've got a lot of distance to cover to get into hospitals and all those complexities. And at every location you go to, we've got new issues to face. And I can see we've got a global audience here in the chat too. We've got Ruhi from Dubai, of course, Soren joining us from Denmark. I think everyone's up at an inappropriate hour to have this important conversation today. But look, we're super lucky too, because Soren, as I understand, this has been your world for quite a while in trying to understand what role technology and solutions can play in addressing some of these issues. Is this where amPHI comes in?
It certainly is, and you can say the essence is that what every patient wants to experience, you can call it a flow, a seamless flow, going from effectively calling or the 000 or 112 or whatever you call it in Australia, and into the and into getting the right care. And the reality is that if you want seamless patient care, you also need seamless information flow. Because I think it's for everyone it becomes an obstacle if you are, first of all, you're met with, we'll say, another person being, you could say, being involved in your care chain. You have to explain the same again, and you have to somehow carry your own stories through the whole care chain. And that might be a very, very high stress if you are in an acute situation. So you can see from our perspective, it's really, really important to have a seamless information flow underneath, meaning that we can serve the entire, you can say, care chain with the same information, which means that the patient is already met with a personnel that is already knows the situation, already understands what's already been said and written, and can meet with additional questions if necessary. So it actually also from the patient side creates a lot of comfort because, well, they know who I am. They already express what I've already expressed earlier.
Yeah.
And just to be a little bit going a little bit back, because I'm often met in the daily life with people that have been in contact with our system. It's national in Denmark, and it's actually I get these good stories that people are actually amazed because information they have left maybe on the CAT center or maybe to an earlier paramedic. They really they state that it's very, very obvious for them that information was already in hand with that paramedic that is taking care of them now. They come with questions, say, "Well, you were the one with the back pain, after the road accident, or whatever." And for them, it was actually a very, very positive experience suddenly to feel that information given and left a lot earlier in the chain was actually carried forward and within the chain, which meant that they could both become the patient, become relaxing instead of becoming the information carrier.
Yeah. Well, look, I think about my own experiences, and admittedly, it's a bit of a small sample size, but from my, when you're in the need of an ambulance or a transport into a healthcare setting or hospital, typically the paramedic is going to be there and do whatever they can to just get you in and out as fast as they can. They've got a high sense of urgency, and I appreciate that you want to have, like, they want to be well equipped with all the information and have every bit of data available to them. But I don't think there's room in the back of those trucks for a workstation on wheels and a full-blown EMR. So, Stacey, from your side, and I guess Soren gave some good examples of globally, but in reality, having real-time access to information for paramedics, like, why is that, like, necessary when sometimes a lot of the times, they just, they're trained to just get there, assess the situation, and get out, if you know what I mean? Help me understand that a little bit
Mm,
more.
Sure. I mean, it's beneficial for everyone in the care chain that's looking after the patient or is responsible for their transport or coordination or anything to have access to real-time information. But given the geography we have in Australia, it is not uncommon for a patient to be handed over in care from one ambulance to another. It could be from a road vehicle to a helicopter and back again. So sometimes patients are in the ambulance. In ambulance care for quite some time, and exchanging that information and being able to see, what the next person in the care chain, what's already happening with the patient. There's a decrease in handover times, and then coming from an integration perspective, being able to pull in any past histories that the patient has. So they're not having to, confirm that with the patient or have to extract that from the patient. Not everyone is able to accurately give that history. So being able to have access to that real-time information and have that real-time sharing of that information allows for one, better informed clinicians, and to share that, so better collaboration. And if you're talking about how a lot more inpatient care is, the trend is that it's starting in the pre-hospital sector, that, in ambulances, they're doing a lot more in ambulance that traditionally was done once the patient was in hospital and assessed. And, so there's a real change in that shift, and having access to that information is imperative.
Yeah. No, that makes sense. And I guess from a patient perspective, if a patient is lucky enough to have a carer or someone, family or whoever is there to be able to provide some context, but that's not always the case. And that's also a very high stressful situation that's often fraught with humans saying human things
Yeah.
under pressure. So being able to equip or enable those the be it paramedics, be it providers that are at that stage of the transportation is going to be pretty critical. I can understand that one, and I think about Soren, from Daedalus's perspective, I know that having solutions built that have been designed with the clinician in mind, and kind of created that are kind of shaped around the needs of those that are providing the care. This, in amPHI specifically, in these solutions that are focused on the pre-hospital care side, why is that? Like, is that a factor? Is that important in the creation of a tool like this?
It very much is, and I think for just as a kind of a fun fact, most IT infrastructure today is actually is built upon information from the hospital side usually, and
Yeah.
designed from the hospital side. Reality is, in my opinion, they should take the origin in the pre-hospital, because that's where you have the wild problems. That's where you get all, you can say, all the rim areas touched, because you can say the pre-hospital setup, the pre-hospital situation is a lot more uncontrolled than a somewhat controlled hospital environment, which means that you push limits and you push technology into areas where you have never seen it before. It also means that we have to be very, very aware of the end users here. Paramedics are incredibly good at finding solutions in every kind of situation, because that's what they train for. If you have an obstacle, overcome it somehow, and they do. And actually, that goes directly into how we design the system as well. Because if we have a flaw or some problem or say a bad design in the system, they will overcome somehow, and we have to fix it afterwards. But again, it easily becomes very, very messy if it's not very, very simple and very, very intuitive, because they are in a lot more stressful situations out there than in the usual context. So what we actually did was to sit down with the paramedics instead and say, well, if we were to digitalize, first of all, your handwritten patient record, how would you imagine that would be done? And actually, 20 years ago, we were the first one to apply touch-based tablets in, we'll say, in a pre-hospital context. That's 20 years ago, which gives a whole new set of use cases. First of all, of course, that is a different way of using the system. That was quite uncommon. Today, you expect that. That's how it is today. But it also gives you new problems regarding how visibility in sun and so on, and in harsh conditions, how to manage it. What if they forget it on the top of the roof on the vehicle, and by the way, drive off. So by asking the people in this field and using the, per se, people in this field also as the testers in the end, is really, really enlightening. And that's been one of our primary drivers over the years, is to ensure that we design for the end user, not design what looks nice.
Yeah.
So it's so I would say it's for users today. Sometimes it looks clumsy, but reality is things have to be a little bit clumsy if you are in a moving ambulance or moving helicopter and try to touch a button. Yeah. So there's a different context we have to put on top of that, and of course the experts in that in pre-hospital context are the paramedics. So often.
Yeah. It's how often that's kind of overlooked in the design phase, or perhaps it's one particular individual and their workflow, when often it can be the there's such diverse workflows that to have a standardized system that then fits in with the rest of the care is going to be a complex thing to do. And I guess, as this has been your world for a long time, Soren, so you've seen every kind of iteration and evolution of that. Just a reminder for those that are in attendance live, as we're recording this podcast episode, which will be released in 4 or 6 weeks out on the Talking Health Tech feed. Good, unique opportunity for you to participate in the conversation through the chat and help shape the conversation as we continue on and dive into, I guess, the complexities and the need to solve some issues around pre-hospital care and the role that technology can play. Here with my friends from Dedalus. So, Stacey, in looking at, the the importance of, we've touched on the need for getting that in that design phase, having the solution that's right and having the clinicians engaged in that process, the paramedics, that whoever's providing that service to then get the patient into the care. And that's great that it can kind of, potentially feed in some information from the site so that people aren't going in cold. But I guess that information's got to go back the other way as well. And also, we know in healthcare, integrating in different systems is no mean feat. And normally where a lot of people cry in a corridor, quietly, well, at least I'm just drawing from my own personal experience in trying to implement some of these solutions. So, so from your experience here in Australia, like, how do you go about that? I guess, integration side, or help me unpack this kind of, because every hospital's got different setups at different
Yeah.
stages of digitization, and everyone's kind of aware they need to do some stuff, but it can kind of feel a little bit overwhelming for project managers, hospital executives, for anyone
Sure.
responsible for the technology side to say, hey, how's this actually going to fit into it? Sounds great in theory, but like, what does that look like in practice?
Yeah, sure. So I guess one of the, the big advantages of amPHI is that it provides that information without, to the hospitals without necessarily true integration. There's browser-based dashboards that are available that receiving hospitals can log into. We can go that next step too and integrate discrete data or PDF or those kinds of things into the patient EMR. But for visibility to the hospitals, it's not a whole lot of work that they would need to do to be able to view that information and access that information and integrate with the interact with the ambulance, not integrate, interact with the ambulances. And like, from my personal perspective, I worked, as you said earlier, I worked as an anesthetic nurse in a big tertiary public hospital here in Brisbane. And many times, we would get trauma alerts, and the only information we would have is that, they were a multi-trauma and they were 10 minutes away. And being able to log in and see exactly what's happening in the back of the ambulance and understanding what the status of the patient is and what treatment they've had so far and how they're reacting to that treatment really helps. Would have really helped me to get ready and prepare and know what, as a team, we need to be ready for once that patient arrives. So I think, it's got a lot of advantages that are outside just the ambulance, having access to that information and being able to collaborate and talk with hospital care teams. As we said, lots of stuff is happening in the ambulance that didn't used to, but we're opening those doors and trying to expand that, that care chain.
Totally. And Soren, you must see this from a global perspective too. Have you got any other perspectives on that?
Yeah, I think it's integration is often an obstacle, as you also write. But reality is that the best driver you can find in the world is to have a shared common vision for all stakeholders to understand. And I think that's where we are in a really fortunate situation here, because reality is that it's very, very easy for everyone to understand, the power of a paramedic understanding past medical history of a patient, for example, if you have alerts, if you have allergies and similar. That means that we have a very, very good message that is being conveyed through the whole organization. Everyone understands the need. And as everyone understands the need, also, I think my experience is that people tend to work in the same direction then, because if you wanted to, if you wanted to succeed, well, you will make it succeed in the end, and then overcome all these legal obstacles and of course all these agreements that need to be made. So I think the message here is very clear and crystal clear for everyone, which means that that a lot of these, you could call it mental obstacles, goes away, because it's a very shared vision for everyone. Everyone knows you have to collaborate, and when you have to collaborate, you also need to share information. And that's how it is. So I think it's we are on a good path when it comes to integrating between these different, not just systems but also different organizations.
Yeah. No, I can see looking at the chat too as you're talking that is definitely resonating with others in attendance too. I can see Ruhi's kind of already flagged, this need for the two systems to connect, and we can elaborate that on if we want. But we've also got, Melissa has highlighted that even before we started talking about it, and that's obviously continued on some more conversation on the need to have that right infrastructure and the capability to be able to continue to do that, as Srujan's pointed out. Ian's kind of built on the issue further on making sure we've got all those connections between the different levels of care too, which is a complicated one, particularly in Australia, be it primary care, tertiary care, public and private. So it is a bit of a labyrinth, but that draws on your point earlier, Soren, of the need for collaboration. That just doesn't exist in the tech side of things across healthcare systems too. But in order to be able to have the data available, to be able to kind of I guess be transmitted across different health systems, it's got to be digitized, it's got to be in a format to be able to do it, and you've got to have the right system to be able to do it in the first place. So that's going to be pretty critical. As we continue on and looking through, please do keep those comments and questions going in the chat, because we will reflect on those in a second, because one just drew my attention. Actually, I think it was Vincent from memory as well. I'd be interested to get your perspective, Stacey. Yeah, here we go. The issue around give us some room here, but the having patient transportation in remote locations. I touched on this earlier, Stacey, that the geographical distance piece is a important one in Australia, one that many health systems need to grapple with, and the role that paramedics and transportation play is huge. And it's not just it's not like the patient's going to be in the same situation from start to finish. Are there examples, or are there I guess from your own experiences too, about reflections on some of these extra challenges that are faced from the rural and remote side?
Yeah, well, I guess that's the advantage of having multiple people able to access the chart at any one time, anyone that's associated. So in that sort of scenario that Vincent had in the chat there, the rural hospital can't treat them, and so maybe it's back onto the paramedics or RFDS, or to transport that patient out. Being all aligned and being able to share that information, and by share, that's not just the patient chart. They can share images, they can share ECGs, and get that sort of response back. So there is that capability to have that chat function backwards and forwards. This is what's happening with the patient. Can you have some advice on what we should do now? And all of that is saved in the patient record as well. So it is really trying to promote collaboration of care and continuity of care down the whole care chain.
Yeah, absolutely. The something that someone has brought up too in the chat, Soren, interested in your perspectives of I guess some of these, as Jadamanji's pointed out, there's different systems that are used and outdated, and there's all these other kind of, everyone's at different stages within healthcare systems. I always like to look abroad too, because I'm quite familiar, as Stacey would be too, with the Australian region. But I'd love to be able to, and from back in my day of implementing systems, be so lovely to just turn off one and have a bit of time and then turn on a new one, and then it's kind of everyone's using the same thing. This messy blended approach, what does that look like in reality in going, okay, we're going to do this thing, but you've got a lot of vehicles out there, you've got a lot of things happening. Is it a big bang? Is it like, what does that look like in practice?
It looks equally messy today, unfortunately.
What's true, I guess.
But it all depends, again, in the kind of organization you're in, and of course in the maturity. In the end, what happens in the pre-hospital area is that we touch base in a lot of the other IT systems as well. It means that we have a lot of integrations, we have a lot of information exchange with other systems, and of course, if they're very old, they usually have proprietary language, the protocols and so on that we are to potentially use. What's good is that we have a lot of standardization ongoing, actually in all products. And I think today, for example, the HL7 or FIRE standards is something that is well, acknowledged all over the industry. which means that it's getting easier because you can say we start to use the same protocols all over, and it's about letting the ends meet, would say meet probably in the end. But it's you can say it is a little bit of a messy area when it comes to the pre-hospital, because you're totally right. We have a lot of devices, we have a lot of different systems we integrate with, and of course the life cycle, as you would call it, it has a certain lifetime whenever you implement a certain tool. That life cycle has to be taken into consideration when planning as well, not spending all your money on something that is to be deprecated in 1 year anyway. So we get involved in a lot of that life cycle management as well, let's say when it comes to other IT systems and other medical devices in use let's say in ambulances and in the pre-hospital context in general.
Yeah. No, it's a really good practical and the real world of some of these implementations, and you've got to have the as we always talk about on the podcast, getting that buy-in from the clinicians, getting the buy-in from the providers, and regular communication. But it's still going to be a process that you've got to resource for and budget for appropriately. Look, I think it's great. We've got so much happening in the chat. I'm wanting to keep up. Nadia has brought up that it's a challenge. I feel like this comment escalated quickly to the point of microchipping humans, but maybe I've misunderstood her comment there. But I appreciate the sentiment here, which I think is important. That and I guess it speaks to some of what we just talked about too, which is that we do want all the data to flow seamlessly together and connect. There's commercial realities, and there's other not even commercial political factors at play, and we all know those in the healthcare setting because we face some of those challenges on a day-to-day to implement solutions that look good on paper, but then they you end up with something else. I guess these sessions are about advice and learning from practical experience and real world examples. I guess, Stacey, from your experience, are there any kind of reflections you can share based on whilst it would be great to get to this utopia, euphoria kind of level of everything seamlessly flows together, but in the meantime, let's do 1, 2, and 3. I'm going to guess that potentially there's a bit of a phased approach to implementing some of these solutions. Or help me out understand how you get from 0 to 100.
Yeah, I mean, there can be. And we know that in Australia, there is a real move for fire standards interoperability. So healthcare systems can actually talk to one another, and it is a while off. But the groundwork has been set, and the wheels are in motion. So one day we will have those beautiful standards in our data, and we will be able to exchange that much more seamlessly. But in the interim, there are lots of ways that that information can be shared. And, we talked a lot about EMR integration, and, we can do, a PDF for lack of integration to an actual EMR that can be exposed from amPHI and be made available, so that whilst it's not discrete data points, there's still that chart that's available, and it takes away that need for paramedics to have to print that record off to verbally hand over, the entirety. There's a real ability for them to use the amPHI web view and have a lot of that information available to them that they could then import or put into their EMR systems before the ambulances are even handing over. They're already aware of that kind of stuff. So yeah, sure, there is that ability to look at that and then go to that next level and integrate discrete data to an EMR.
Yeah. Well, look, I mean, that speaks to the point that I think Vincent was raising earlier, or at least that's tip of the iceberg. It's you can have the best systems that connect seamlessly and all of that, but if you don't have a connection, it's kind of you need to have you need to have options there to be able to work with the environment in which you're in. I like Marianne's point too, that she's raised that it's you can focus a lot on patient care, but paramedic safety is also paramount too. So being able to have access to information up front, as we've heard plenty of examples there when that's come into play. So do keep those any other final comments or questions going in the chat, because I want to throw to our guests for kind of reflections and I guess longer term thinking around it. I think we've touched on some of these points already, but I'd love to kind of get put a cap on some of these. I might start with Stacey and then let Soren kind of summarize. But then if we're looking to the future then, and you think about some of these long-term benefits of implementing solutions, we do the grind and we do the hard work, and we all sing Kumbaya, and we're maybe not that far, but then we all kind of collaborate, which is the theme of every Talking Health Tech episode. Using platforms like amPHI, this continuous evolution of pre-hospital care. Where do you see these technologies going and transforming patient care?
I mean, in a perfect world, it would be amazing if there were shared care plans, So we're starting the care of the patient in the ambulance, and that care and that initiation of care within the ambulance is really part of the continual care plan of the patient, and that's aiding to decreased hospital inpatient times, and improving those discharge times and improving those patient outcomes. I mean, that's the utopia, isn't it? That everyone's on the same page. It's very difficult, though, putting that into practice, but that's the aim of the game, really, to help clinicians talk to one another and collaborate together and really make this a continuum of care, not episodic care. It isn't just this happens in the ambulance, we're done, and now we're handing over to the hospital, and now you do your bit. It's really trying to get all of those care teams to work together.
Yeah, super important. I like that. And Soren, what about yourself?
Well, actually, things are improving already, so the future is already here, and I think that's very important to see, because what we see from the sideline when implementing, the systems and adopting these kind of systems within the pre-hospital care is two things. I think number one, and that is really important to understand, is that historically ambulance service has been driven by time as the quality indicator. How quick are you? Are you fast enough to dispatch? Are you fast enough to get to the patient side, to pick up that patient and run them into the ED? And that's the old-fashioned mindset when it comes to the ambulance care. Reality is that introducing systems like this means that you get a lot more detailed insight in actually what is going on, which means the quality indicators becomes vastly different. You start to focus on patient outcomes instead of focusing on speed, which is of course what the patients in the end are interested in. It also means that you're in a better position in measuring whether you actually apply the right resources at the right time. So we see, so after adopting a system like ours, what we generate vast amounts of information. And when you start to understand and utilize that information, we start to see quality indicators shift, and also start to exchange information, not just with the pre-hospital, but also with the EMR systems at the other end, to see what actually happened with that patient after admission to the hospital. So that's one part. Number two is that, well, for you to do improvements, you need some platform, you need somewhere to apply your improvements towards the organization. So it means that if you create a new patient care path, for example, which Stacey is also touching upon, you need somewhere to apply that care path. You need somewhere to communicate what to do next. What's the latest, you can say, decision making within regionally or nationally regarding how to manage this particular patient group. And for that purpose, we also create customized care paths in the system itself. So that means that if you are in an inclusion group, within a given patient group, you will get into standardized care paths where you are to go through the same assessments and eventually follow the same care path, which has been determined from a higher level, from a more strategic level. So that means so introducing a platform like this actually makes a huge difference in the operations in the end. But it's an involvement. You start with introducing the system and start using it, and from there you start to get the benefit.
No, that makes a lot of sense. And I love the continuum of care concept and thinking about that as our kind of North Star. During the kind of wrap up there, I did see, Janamani is sharing that it's We love our bits of paper in healthcare, don't we? Even though we can get rid of them, we still want to save them. I know that's not Jumanji wanting to do it, but the system wants the bits of paper. But there's as we shift towards more digital solutions, hopefully we can influence the system upwards. But I guess that's the case, isn't it? State by state across Australia, and Ruhi from Memories in Dubai as well is resonating with your points, Stacey. And sometimes, from my understanding of Ruhi's comment, is that it's great to have all the information available to us, but we don't want this big fire hose of information, because then we get alert fatigue or information fatigue, and you got to have the right information at the right time and the right etc. We do all of those. Melissa did raise a question around the integration with My Health Record. Because it's interesting, the My Health Record piece is, it was the dream was sold to all Australians that if you're in the back of an ambulance, the paramedic will know what medication you're allergic to, because they'll just whip out your My Health Record and know straight away. But is that a part of the whole kind of ecosystem?
It's a possibility. It could happen. It would be dependent on the requirements of the ambulance organisation that we're working with, and it would be also dependent on what the patient's wishes are. Some people, despite having a My Health Record, they don't want information included on My Health Record. So we have that ability within amPHI to be able to indicate if the patient does want information blocked. But also it does have the ability, if they do want that, there is the ability to upload the record.
Yeah. I can only imagine from your side, Soren, on global perspective, the amount of requirements to have a system at scale across the world that's, uniquely tailored to each region's requirements. But I know that the Australia-New Zealand region is particularly important to Dedalus, so it's great to hear some of those kind of nuances are made and the requirements are there. So look, for those in attendance of this live podcast recording, I appreciate you coming and help shape the conversation. You'll be able to catch this episode in a couple of weeks on the Talking Health Tech podcast. Soren, Stacey, I really appreciate you making the time. We'll put some details in the show notes of this episode, and Dedalus have a strong profile on our Talking Health Tech website, and there'll be more information available there for those that want it too. So thank you so much for your time.
Thanks, everyone.
Pleasure. Thank you.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe, and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.